Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC, here with an update on the COVID-19 pandemic. This week, we'll cover the state of global COVID and the state of U.S. COVID. We'll also review a continuing wave of new results on long COVID. This at a time when establishment public health has thrown in with the political class's efforts to just declare the pandemic over. We begin with global COVID. In the top graph, our world in data using WHO data reports us at 428,000 confirmed global cases this week ending April 19th, a low we haven't seen since April 2020. The bottom graph shows us at 2,129 confirmed deaths, which we haven't seen since March 2020. This is at a time when countries around the world are also reducing surveillance. The US is reporting 1,000 plus deaths this week, and it's highly unlikely that the US is hosting half the world's COVID deaths. That said, we do also see from the Economist's data set of the 7-day average of excess deaths per 100,000 population, a decline in excess deaths toward pre-pandemic levels. Those bumps off the floor include in orange, Spain, Ireland, Libya, Russia, Lithuania, Albania, Croatia, Bangladesh, Thailand, and Vietnam. Using WHO data, our world in data also shows weekly hotspots as of April 19th. Of the countries reporting in, Europe, through Russia, is reporting the highest figures, but almost all, save France and Austria, way less than 1,000 COVID cases per 1,000,000 population. Our world in data warns, however, that confirmed cases are lower than the true number of infections due to limited testing. At the same time, we see from these percent changes in caseloads the past couple of weeks rebounds, they are in the warm colors, are still scattered across the globe. In the Western Hemisphere, Brazil, Panama, and the Dominican Republic are reporting large increases or large as percents of their previous levels. Europe is largely leveled off. Across Eurasia, Afghanistan, India, China, Thailand, Vietnam, Laos, and Indonesia are showing stiffer increases. In Africa, Morocco, Libya, Egypt, and Sudan are reporting increases as well. And at a time when the vaccine strategy many governments say they're pursuing instead of non-pharmaceutical interventions is faltering. I mean, much of the world is at best vaccinated for variants no longer circulating. We see uneven campaigns in booster vaccination across the world. On the one hand, Chile, Peru, Uruguay, Cuba, Canada, Belgium, Finland, Germany, Italy, Australia, and Japan show top-tier booster campaigns with 70 or more booster shots administered per 100 population. In contrast, we see near nothing in Russia, India, Pakistan, Indonesia, and those even reporting in from Africa, as well as mediocre campaigns in the US, Mexico, Brazil, China, and Eastern Europe. This map hasn't changed much, although reported here to be updated April 18th, indicating these campaigns have largely ground to a halt. Indeed, the CDC reports the US still at 16.7% of its eligible population, 5 years and older with an updated booster dose. And we can see from this time series a combination of some countries no longer reporting in their vaccination, but almost a universal tailing off of new vaccinations since spring 2022. Now, in the interest of trying to get you some sense of the nature of the pandemic, the People's CDC has been cobbling together these kinds of data across different variables from the start of our broadcast here on COVID this week. But as the People's CDC's own Howard Waitskin, a medical doctor and sociologist, remarks, there are plenty of reasons why these data are problematic. In the previous COVID This Week broadcast, we started a series of observations about data. We talked about the variation in the definition of what comprises a COVID case. This episode will discuss the issue of variation and error in a statistical sense. Many data, Waitskin observes, involve statistical estimates such as averages, means, medians, and other indicators of central tendency, or percentages. A common practice in assessing such estimates involves measuring the variability or spread of observations around the average or percentage, as at the top. Examples of such measures include standard deviations, confidence intervals, and similar techniques. Waitskin continues. Measures of variability rarely appear in reports and even statistical models of COVID-19 at all geographical levels. A lack of such measures make it more difficult to assess the validity and reliability of the estimates using measures of central tendencies and percentages, as shown on the bottom. End quote. In other words, caseloads and deaths are often posted on dashboards with little sense how supported such numbers are, given the variation in value of the reports combined into such sums. Empirical data are important, but numbers without support may offer a false sense of security that the system is keeping track of the pandemic. We'll address other data problems in episodes to come. Meanwhile, the mediocre vaccination campaigns, hand in hand with the rollback in the non-pharmaceutical campaigns that successful vaccination depends on, have been taking place alongside the continuing emergence of multiple Omicron subvariants now circulating across large expanses of the world. XBB 1.5 has surged across the world, pushing back BQ1 and BA 2.75. XBB is holding on, especially in South Africa, which is also still hosting BA5. For other countries, we're drawing from covariance.org. We see XBB 1.5 coming on strong in Japan, as is the case in Russia, with XBB still holding on. We see XBB bouncing back in India, probably on the back of the new sublineage XBB 1.16. South Korea appears hosting a balanced mix of XBB 1.5, BQ1, and BA 2.75. Hong Kong is hosting XBB 1.5, XBB, and BA 2.75. Sweden appears hosting a fuller mix of XBB 1.5, XBB, BQ1, BA 2.75, and BA5. As he did with the emergence of XBB 1.5 out of New York State to the rest of the world, data visualization specialist Mike Honey maps here the emergence of XBB 1.16 out of India. And we see the classic geography of any pathogen emerging out in the world, making its way to local cities, in this case in India, before hitting the largest international cities first, in this case, London and New York, before diffusing down the economic and population hierarchy of the world's other cities. Joining what Raj Narayanan shows is the world diversity of sequences the past 20 days as of April 23rd. Yes, XBB 1.5 is leading the way in light blue, in part due to the sampling bias toward high-income countries, but we see many subvariants and sublineages in play, including many XBBs, including now in purple our XBB 1.16, but also BN, CH, DU, XBF, and XBC, among others. While some evolutionary hounds remain on the case, the world's public health establishment, including the WHO, has apparently stopped keeping pace with the SARS-2 virus, omitting to name all those newly emergent lineages as anything other than subvariants of Omicron, despite their massive shift in evolutionary distance and specific amino acid changes that previously called for new names. As evolutionary biologist Ryan Gregory points out here, all these new SARS-2 are being stuffed into the Omicron drawer. Biochemist Richard Kao reports XBBs 1.5 and 1.16 are displaying explosive relative growth advantages out in the world, in part because they've evolved upon amino acid replacements, permitting them greater immune evasion, particularly in the receptor binding domain of the spike protein at amino acid position 478 on top and 456 on the bottom. But letting COVID rip, whatever we call the new lineages, has only let the virus evolve out from underneath our natural immunity. A German team shows Omicron is escaping neutralization by antibodies induced by prior infections and vaccination. They show that antibodies in saliva that can contribute to protection against recurrent SARS-2 infection declined upon the emergence of the Omicron variants in a cohort of 1,850 children and adolescents monitored since the summer of 2020. While 37 of 54 youth with pre-Omicron infection there on the left in dark blue had wild-type receptor binding domain reactive immunoglobulin G in their saliva, only 32 of 173 there in the first yellow were IgG positive after an Omicron infection. The relationship held across epitopes and variants. In contrast, vaccinated children on the right in gray still had reactive IgG almost to a 1. Letting COVID rip has also permitted the virus to evolve out from underneath vaccine protection. A Cleveland Clinic team showed in its cohort of thousands of clinic employees, the bivalent booster vaccine effectiveness was 29% under the BA4, BA5 variant era, 20% during the BQ era, and only 4% during the XBB lineage. All these are within specific confidence limits to get back to Howard Waitskin's point about measures of dispersion. So even under XBB, the bivalent offers something, but increasingly also something only marginally effective. It's like the effectiveness of our vaccines are tied to the effectiveness of the non-pharmaceutical interventions many countries have willfully abandoned, letting COVID evolve largely unimpeded. And the damage extends far beyond immune reaction. Long COVID is proving hideous in all its manifestations. In the latest of a series of studies, a British Columbia team showed a significant increase in new diabetes cases within a year of being infected with COVID-19. The large study of 125,000 COVID patients and 500,000 unexposed patients before vaccines were introduced showed an increase in diabetes incidence in COVID patients of 3.4% off a baseline of uninfected patients shown here. The effect was particularly marked in male patients, showing an increase of nearly 5%. The team also showed the greater the illness caused by COVID, the greater the likelihood of getting diabetes. The team matched infected and unexposed by age and sex and controlled for underlying health conditions, socioeconomic status, and vaccination status, among other factors. Now, while there is a chance those who are getting treated for COVID are more likely to get the medical attention that diagnoses other illnesses, including diabetes, there's also a direct biochemical mechanism for the clinical outcome. SARS-2 directly infects and kills beta cells in the pancreas that make insulin we need to stave off diabetes. Beta cells are studded with the ACE2 receptor that the virus uses to enter host cells. The inflammation associated with the COVID has also been linked to beta cell death. A Taiwanese team reports that in a retroactive study of a cohort of more than 1 million people, those infected with COVID-19 without a previous history were more likely to suffer complications of herpes zoster, the reactivation of the virus that causes chickenpox, within a year of the initial COVID infection. The relationship held across age, sex, and vaccine status. A team of Chinese and American scientists led by Desheng Wang reviewed work around the mutual activation across viruses. Their review highlighted a 2021 paper that showed COVID-19 stimulates human endogenous retrovirus K, or HERV-K, which is involved in inflammation, cell-cell infusion, tumor development, and metastasis. Turning to the US, the Walgreens COVID-19 Index of National Test Positivity that COVID this week has been using hasn't been updated since April 7th. We now post the CDC state map of 7-day % positivity for the nucleic acid amplification tests, with Missouri and South Dakota topping off in the quintile of 15 to 20% COVID positivity. The CDC reports the latest round of excess deaths during the pandemic above the average deaths the 6 years before the pandemic. The last month reports a decline under the baseline. That may be a measure of true decline, but given our reading of the figure over the past couple months, likely also represents data still being collected across the US. Here, the CDC's community transmission map, which is based on 1, new cases per 100,000 population the past week, from a low of less than 10 cases to as high as over 100, and 2, the % positive nucleic acid amplification tests for the past week, from less than 5% positive to over 10%. We see that Iowa is no longer reporting in. We see the West Coast hosting moderate outbreaks, save a county here and there. The Southwest appears getting hit hard. We see Alaska, Nevada, Utah, Eastern South Dakota, Missouri, and Puerto Rico also hit. We see Oklahoma, Mississippi, and the Rust Belt, from Illinois east to New York State, cooling off a bit. Now, we may be saying goodbye to this map shortly. The CDC is reported to be ending this transmission map upon the end of the public health emergency slated for May 11th. Another mode of tracking COVID-19 converges upon this cooling off. We see the levels of SARS-2 virus detected in the wastewater that comes through our sewage plants. In some ways, a leading indicator of the pandemic for April 9th through April 23rd. In the oranges and reds, we see plants at 60% or more of all the samples in the SARS-2 detected taken nationally since December 2021. In a few spots west, less so now in eastern Nebraska and in parts of the industrial Midwest, particularly Ohio. The East Coast, save a couple plants in Maine and North Carolina, is cold. On the other hand, the more acute measure of changes in sewage loads over the past 15 days shows some areas heating up more than others. Here and there along the West Coast, the Idaho-Utah border, Colorado, Missouri, in and out of Wisconsin, Illinois, Michigan, Ohio, and across the East Coast, from the Carolinas up through Maine, although less so than a week ago, now largely concentrated in Pennsylvania and the Carolinas. These could be threatening spikes or increases off a lowering floor. Here are the 7-day averages of fractions of hospital beds filled by COVID patients in 3,800 plus hospitals reporting April 15th through the 21st, mapped by the People's CDC's Les Schaffer. We see Oregon cooled off a bit, as well as Phoenix, Dallas, and Florida, although 600 fewer hospitals reported in than last week. Chicago appears heated up, and Philadelphia still seems hot. To sum up, here's the People's CDC version of our present community transmission by county as of April 20th, mapped again by Les Schaffer. This map shows the combo of caseloads and test positivity that the CDC plots, but unlike the CDC, the People's CDC differentiates the high level of danger counties are subjected to beyond 10% COVID positivity into high, very high, and extremely high exposure. Down at the bottom, we see that the People's CDC also differentiates exposure by both the percent of counties and by the percent population. As we remarked earlier, Iowa isn't reporting in. Overall, we see a continuing spatial contraction here in the US, including the West Coast, although Oregon appears more filled in, as does Minnesota. The Plains, Illinois, and Indiana, Appalachia, the South, and up the East Coast are hosting lesser exposure. The Four Corners, Eastern Dakotas, and parts of Oklahoma and Missouri still appear filled in. Those few counties in the very high and extremely high categories might be good places for sending CDC teams to tamp down outbreaks that could serve as domestic sources for a national rebound. But for now, we're down to 14.6% of the American people in communities subjected to high to extremely high COVID exposure, and only 0.05% in very high and extremely high. And that's terrific news, although that may be in part dependent on reductions in testing. And we still have another 16% subjected to substantial exposure. So yes, progress, but not at a level yet to declare a public health emergency over, with 94,000 confirmed new cases this past week and 1,160 Americans dying. The outbreak stateside continues to evolve, with here the continued dominance of XBB 1.5, but also now the emergence in the soothing blues at the bottom of XBBs 1.16, 1.51, and 1.91. With 1.16 bumped up to nearly 10% of new sequenced cases. Here's the 15-day trend of all the genetic sequence of detected sublineages in the US as of April 25th, including their geographic origins. XBB 1.5 in blue is still ahead in states across the country, but beginning to give way to other XBBs. There are all sorts of subvariants of sublineages circulating in such a way as to offer possible candidates for the next dominant variant, or to contribute to the next recombinant that accelerates beyond both the vaccine and population immunities that we were discussing earlier. Indeed, all eyes now are on new sublineage XBB 1.6 in red, spreading out from New York and California, reported to cause more cases and deaths in India. It is now spreading here stateside, as is XBB 1.91 in brown. Now we're going to end the broadcast on this note. While COVID chugs on, the near entirety of the public health establishment chugs on only in demanding the end of the public health response. For instance, much attention was placed on a January Cochrane Library review of the effectiveness of masks. The review came down against mask mandates, but as we described in a previous COVID This Week, was riven by technical problems despite the library's reputation. It didn't help matters that lead author Tom Jefferson, who has written commentaries for the Minimizer Brownstone Institute, used his media appearances around the study to pound the bully pulpit on his own decidedly anti-interventionist views on public health. Appearing on Marianne DeMassi's show, he denounced the Swiss cheese model of intervention that uses a combination of interventions, each with its coverage, each with its holes, to cover up the gaps in each other's intervention. I like Swiss cheese to eat, Jefferson said. The model, not so much. It's predicated on us knowing exactly how these respiratory viruses transmit, and that I can tell you we don't know. There's no evidence that many of these things make any difference, end quote. In other words, because we don't know the nature of every aspect of every virus, we do not have evidence to support doing anything, which in effect rolls back the entirety of nearly 150 years of modern public health. But reviews of the reviews since have further unpacked the problems with the study Jefferson helped lead. The problems are exactly with the nature of evidence and approach the authors claimed they themselves were attacking. First, the review included only 2 studies about COVID and masking. The review wasn't about COVID so much as respiratory viruses overall. Combining studies across pathogens with different modes of spread undercuts the basis of a meta-analysis. Secondly, the absence of evidence that masking works would not represent evidence of absence. As epidemiologist Alexis Dino remarks, quote, if you want to show evidence of absence, you should really be using some form of equivalence testing or better yet, relevance testing, but such methods were not reflected in the review, end quote. In that vein, Peter Dorman commented on the Spirit of 1848 public health listserv that the problems with such squishy meta-analyses is that they presume a common population over which all these studies are drawn, and that adding all the samples together only increases statistical power rather than conflating populations, especially as many of these studies did not draw from random samples as measured across the combined populations. Indeed, the review's own authors pointed out the variation in outcome measurement across the studies and the low mask adherence in many of the effect samples. Another group led by Raina McIntyre noted that mask effectiveness depended on whether the participants wore their mask continuously or intermittently, and where, in areas of high ventilation or low, for instance, things the Cochrane Review did not tackle. Thirdly, as a team at the Center for Infectious Disease Research and Policy declares, the droplet dogma of spread the review presumes has largely been replaced by the aerosol model. COVID is airborne. CIDRAP adds, it's not that masking doesn't work, but that respirators are more appropriate. On the other hand, many studies have shown both mask and mask mandates work better than the nothing Jefferson claims a lack of evidence must support. Indeed, the outstanding question isn't whether masks work, but why governments gave up so quickly encouraging their use. Now, this minimalist position, now often denialist in nature, has been gaining steam since early in the pandemic. Here in June 2021, San Mateo County in California held a celebration of Mahatma Gandhi Day in honor of the University of California medical doctor who pushed for ending all non-pharmaceutical interventions even before the Delta strain arrived in 2021 and long before the Omicrons hit. But we see here the steady drumbeats of COVID positivity and hospital admissions in San Mateo since that day, June 15th, 2021, continues on to this very broadcast. There's another way toward liberating people back to the town square. Rather than just declaring COVID over with proclamations and days dedicated to denialist doctors, one ends a pandemic by driving the virus below its rate of replacement, exactly with the Swiss cheese model Jefferson rejected out of hand. To start us off, we need keep the public health emergency in place at a time when COVID is continuing to roll on and vaccine effectiveness is retracting. We need to keep masking in medical settings where people sick with COVID converge with people with conditions that make them vulnerable to COVID. Here, last month, organizers from Senior and Disability Action protested outside the Alameda County Department of Public Health headquarters in Oakland, demanding the county implement a mask mandate in area healthcare settings upon the end of California's masking order. As part of a national campaign, the People's CDC is urging people to call and write hospital CEOs to maintain their facilities' masking policies. You can add your voice at the link in the video description. The American people deserve so much better than empty declarations the pandemic is over. And that's COVID This Week from the People's CDC. You can find all our episodes on the People's CDC YouTube channel. You can learn more about the People's CDC and read this week's COVID weather report at our website, peoplescdc.org.